Having learnt about the basics, why we need to diagnose, why we need to treat the patients on GDM, what are all the wider implications of it. Now we will move on to the next module, the second module on GDM. How are we going to diagnose? There are lots of controversies around this. We will briefly tell you like how these guidelines evolved and how we diagnose gestational diabetes in our clinical practice. We'll just take a simple case for us to understand. So we will involve two patients here. So the first patient is 27-year-old female. She comes with 9 weeks gestation. Very simple. Should I screen or not screen? The question is very simple. So why should we ask this question whether about screening? Because we discussed any diabetes or any gestational diabetes is going to happen only in the second trimester, only when the HPL increases and the insulin resistance sets in. So why should we, if at all, screen at 9 weeks of gestation? So not needed, no. That is what our sense tells. But why should we screen at 9 weeks of gestation? That is an important question. So for that we will get the answer slightly later. But whom to screen is an important question. So should we screen? First of all, how we are going to screen we will see later. So should we screen? So NICE says if the woman's BMI is more than 90, if the previous baby weight is more than 4.5 kg, like we said, macrosomia as per the US guidelines, if there is a previous GDM, first degree relative with diabetes, and those belonging to South Asian and other, if they are ethnically predisposed, so these people can be subjected to selective screening is what NICE guideline says. The ADA recommends women at low risk for GDM need not be screened at all. So what we saw NICE was the high risk people can be screened. ADA says if the age is less than 25, normal weight before pregnancy, the member of ethnic groups with a low diabetes prevalence, no diabetes in first degree relative, no history of abnormal glucose tolerance, no history of poor obstetric outcome. So you don't need to screen at all. So that is what ADA says. NICE says whom we need to screen. ADA says whom we don't need to screen. But what we need to understand is there is something like universal approach. Asian Indians, especially Southeast Asians, they are at a high risk ethnic group for the development of diabetes. Hence, all pregnant Indian women need to be screened for GDM. This is consistent with the NICE and the ADA guidelines. So we need to understand all pregnant Indian women need to be screened for GDM. So when we need to screen is a different question. So they need to be screened for GDM. That is the first point that we need to understand. When to screen? So that is the second question. GDM usually develops during late pregnancy, after the first trimester. However, if screening is delayed till that time, there is a chance that pre-existing diabetes may be missed. So we said 5 ways of presenting the GDM patients. So if we don't screen them in the first trimester or when the patient first reports us, if there is a pre-existing diabetes, type 2 diabetes typically, if it or a mild variant of MODY which gets worsened, or if there is a previous impaired glucose tolerance which is worsening now, so those scenarios can be missed if we miss them. So it is ideal to perform the first screening as early as possible during the first antenatal checkup. That is very important. So we need to screen them when they first visit us. So now the women who has come 27 years 9 week gestation, her fasting is 125 milligram per deciliter and her postprandial blood sugars are after 75 gram OGTT is about 160 milligram per deciliter and her A1C is about 8.6. So A1C is higher, blood sugar is 125, 160. So what do we need to do? So if the A1C is higher, so the patient is looks like already she is type 2. So what do we need to, or means A1C is definitely not a normal one. So since the A1C is higher, what should we do over here? This is the confusion that comes. So one thing that we need to clarify over here is Once this point we have reiterated even during the first session. So once we diagnose the patients in the first trimester, always think in the background of type 2 and it is not as GDM. So whatever we typically think for GDM should not be implicated over here. So the fasting criteria is like what happens for a type 2. The blood sugar fasting should be above 125, or the prostprandial is above 2 gram OGTT should be more than 200, or the A1C should be more than the criteria for them to call as diabetic or type 2 diabetic. So this is what is important. Or in case if the symptomatic, if the patient is symptomatic and more than 200 milligram per deciliter, this is the third criteria that we use for diagnosing a type 2 random blood sugar with symptomatics more than 200 milligram per deciliter. So some of these criteria the patient should fit in to call as the patient has diabetes. So the GDM criteria should not be brought in here. So very, very, very important carry home point. So this patient, for them to diagnose as a diabetic, so this criteria is the one we need to use, not the GDM criteria which we are going to see later part. So first trimester, it is the normal conventional way of diagnosing the diabetic is the one which is important, not the GDM criteria that we are going to the later. Many of the people, many of the even diabetologists get confused with this because we don't know what is the implication of diagnosing over here. So this criteria should not be brought to this stage. So the criteria should be based on only these 1, 2 and 3 factors, not this. Having said that, some of them, if the A1C is higher, or looking at asking the patient, because they will be more prone for complications to abort the pregnancy or to terminate the pregnancy. Some of them which I know at least are telling. So this per se is not a criteria for termination of pregnancy. Pregnancy is contraindicated. So the potential contraindicated indications to pregnancy in diabetes is, in case if there is an ischemic heart disease, advanced untreated proliferative retinopathy if it is there, or in case if the EGFR is less than 60, severe gastroparesis, or the blood sugar is not absolutely controlled at all, like it is haywire, like 300, 500, something like that. So these are the potential contraindications to pregnancy in diabetes. Otherwise, we should encourage them and take them as an undiagnosed type 2 diabetes and treat the patient aggressively at that stage.